Welcome to Easy to Digest, your go-to podcast for all things health and nutrition. I'm Vanessa Rossetto, a registered dietitian and entrepreneur.
And I'm Benji Salter, a cardiac anesthesiologist. We're so glad you're here. On our show, we're going to cover topics like heart health, gut health, women's health, you name it, we're going to cover it.
Our goal is to make midlife wellness topics easy to digest. So join us as we dive into conversations with other experts, entrepreneurs, and patients.
And don't forget to subscribe so you never miss an episode. You can find us wherever you get your podcasts.
Hello, and welcome to Easy to Digest. We are your hosts, Vanessa Rossetto and Benji Salter. Hey, Benji, how are you?
Hi, guys. How are you? Hey, V.
I missed you. How you doing?
It really has been too long. We don't do a very good job. It's like, the reunions are great.
I know.
We don't do a very good job. You look fantastic.
You are such a witch because you're saying that so
it's true.
sarcastically.
It's true. Maybe it's the lighting, but like look, you know what it is? Oh, great mug. You look
the V.
You look stronger. You look stronger.
Funny. I'm breaking down, but that's okay.
Yeah, but that's you. You always can. There's always that. I don't know, that protective look.
Yeah. Well, I'm excited for today because two of my favorite people are here with us, and I basically flood their office with all of my patients. So I help to keep them earning a fair and equitable wage, I believe.
This is the episode that I think personally I've been waiting for, because I think, as we know, your gut tells no lies. Like, the answer is there. The answer is in your gut. It's in your large colon, your small colon, your stomach, your esophagus. It's somewhere.
Dr. Benji just said large colon and small colon. I'm just there.
In your distal segments, wherever it is, in your small bowels, in your large bowels, the answers are there, and that's what I'm so excited about talking about today. I think we have maybe close to 100 questions. At least I have 100 questions in my brain that I want to ask, and I know that they're going to be frightened. But let's do some intros and let's get this going.
The smartest dietitian that I know is named Tamara Freuman, and she was my TA, and somehow the stars all aligned, and she started to work alongside my favorite gastroenterologist, Yevgenia Pashinsky, who I met when I was pregnant with Rocco, and I was having really bad GI problems. And let's be clear, my GI problems started way before I ever had children or was pregnant, but this is where they were mainly identified. And somehow I made her become my friend. And here we are today. So welcome to Tamara and Pash. How are you?
Welcome, guys. Wait, so are you saying children lead to adult GI distress and stress?
Yes.
And poverty. And
wow.
They're little walking ulcers,
Ladies and gentlemen, a medical breakthrough. Who would have thought that was the case? Guys, welcome. Thank you for being here. Like I said, we have so many questions. The answers are all there. It's funny. I feel like in every other episode we've talked about the GI, just everything. We've talked a little bit about, we talk a good amount about Ozempic, but it always kind of comes back to nutrition and diet and gut health. And, we had an episode about, anorexia and eating disorders, and we get back to nutrition and gut health. And every episode, and thus every stressor, leads back to the gut. Right. And so I think, I got a lot of thoughts. We definitely want to talk to you guys about all of our thoughts and our questions. Let's start with really high level stuff. Okay. Give us a little bit about your background, but why would I, as a patient, someone who's, let's say, 35 to 50-year-old, how do I get to your office? Right. Tell us about your background, and then tell us why are patients kind of coming to see you? Are we seeing a primary care doctor first? How does that whole process work?
So, background, hi, I'm Yevgenia. I am one of the gastroenterologists at New York Gastro Associates. What?
I was walking the dog with Pash the other day, and she told someone that her name was Jen. There, America, you have heard it. Continue.
Your
That was
name
the
has
highlight of
been
her day.
Americanized.
Yeah, I mean, who's going to pronounce Yevgenia? I mean, if it's what? Yeah, there's no point,
There's
like,
no like Evgeny,
I mean, there is.
Jenny. I guess it's Jen.
I literally
Jen
almost
is just the shortest.
I passed out. I was like, "Did you just tell that woman your name is Jen?" She was like, "Vanessa." Really? I was like, "I guess." Like this.
So
Go ahead.
do you want to redo the introductions and say Jen Pashinsky?
Yeah, no, I mean, I'm like Dr. P, Dr. Pash,
Yeah.
whatever anybody wants to call me. So I'm one of the gastros at New York Gastro Associates, and we see patients with, quite frankly, any age group. I mean, obviously we're typically adult GI, so like 18 to, 100 plus until whenever you want to keep coming to see us for any GI element. So we say, starts from the time you put it in your mouth till the time it comes out of your mouth. So anywhere along the way, any complaint or problem you may have, which ranges, anywhere from acid reflux, indigestion, heartburn, abdominal pain, nausea, vomiting, diarrhea, altered bowel habits, rectal bleeding, very routine stuff, colon cancer screening. Everybody get yours done. It's very important. Sort of any of those things, perceived food sensitivities and intolerances, celiac disease, Crohn's, colitis. I mean, there's tons and tons and tons of GI and liver issues because we take care of both, that people come to see us for. And a lot of times, these days, in terms of the only people who really need to see a primary care, before coming in are people who require that insurance wise, but and also those typically who actually have good primary cares who they trust, which we know plenty of. They'll kind of, you see them start the workup, start treatment, and if that is not going as it should, is when they're told to come to us, or obviously if anything is worrisome off the bat that requires an intervention, a test, or some sort of more specialized treatment from us, they would go straight to us at that point. So many roads lead to us.
To the gut.
Yeah.
What you were saying earlier is sometimes patients have to go see primary care for insurance purposes to get then sent to you. Gotcha. All right. I just wanted to clear that up. I mean, where do you want to start here, V? Because
I want to start with Tamara because I have people that come to us all the time and they are basically like telling us about the diets that they need to do in order to like heal their guts and all of the Dutch tests and this food sensitivity tests and the leap dietitian that they saw and the functional medicine dietitian that they saw. And I'm like, honestly, you don't need any of these things. And so what do you say to someone that like comes to you and they're like, look, I got this Dutch test and it says that I have all of these sensitivities. Now I've been on low FODMAP for the last 3 years. What should I do? It's like, I'm always like, you should.
and while you're answering this question, can you translate some of what she just said with a Dutch test and the FODMAP and all that good stuff?
Thank God you're here, Benji, to
Oh
keep us
man.
honest.
Okay, this is a lot, guys. I'm like already exhausted. So, I mean,
We allow one nap per podcast, so you just let us know when it's time.
all right. Well, so hi, I'm Tamara Freuman. I'm a GI expert dietitian. And patients come to me with a cluster of symptoms with varying degrees of either self-diagnosis or sort of more like alternative medicine diagnoses. And maybe a lot of preconceived notions about what the problem is or what diet they need to follow. But if they've come to my office, they're not better, right? And so, whatever you're doing clearly isn't working or you wouldn't be here. So I think that I usually start with that premise, which is I want to hear about your symptoms. I want to hear about what you feel, what you experience. And I want you to save your commentary about why you think it is or, what you were told this is. I just want to hear what you feel and what you experience. Because number one, I want to start with a blank slate. Like I want to assess by myself. I don't want to be led, like don't lead the witness. Like I want to hear and, come to my own conclusions. And also, I think it's important for patients, not to get shot down right off the bat in the first 30 seconds to be like, well, I don't believe it. That's bullshit, whatever. And it really kind of creates was I allowed to say that word on our podcast?
Yes.
Okay.
Yes.
God,
Yeah.
otherwise this is going to be a really tough hour for me.
I mean, it's a GI
you're good.
podcast, so like,
Yeah. We're gonna
word
be
is
saying shit.
synonymous for poop. So
That's like that's a clinical term. I used that
get
clinically just now. You don't want to shoot someone down. You don't want you want to build trust, you want to build rapport. And like all the info I need to know is often in my patient's experience and in their history recounting. And so I want to hear the data from the patient's mouth. And I think when I can say to them, I believe what you feel, I believe that you're experiencing this. I'm not sure I agree with what you were told about what's causing it, or, what foods you think are causing it, or what diagnoses you were told are causing it, but I believe your symptoms. And I think most patients are very open to hearing my point of view, because obviously they've made the appointment to see me, they're paying money to see me. They do want to hear what I have to say. And I think that if they feel validated and listened to and heard, I'm really able to steer the conversation away from, pseudoscientific tests or unscientific diagnoses into the realm of evidence-based practice, which is where I live. Because at the end of the day, patients just want to feel better. They're usually not wed to having a particular diagnosis. They just want to feel better.
And I'm sure they've tried lots of, treatments, whether they're, prescription, over the counter, or something they read about, whatever it is. And so I would hope that they would come to the office and be like, help me, tell me, direct me, all that kind of stuff. Though,
For the most part, there
yeah,
are.
yeah,
And
yeah.
if there's resistance, then I can just say, listen, like you've been doing it this way for a really long time and you're not better. Let's, give me 2 to 4 weeks. Let's try something else. If you hate what I've said, if you hate what I've recommended, if it's not working for you, you can always go back to those supplements or that diet or that whatever. But if you've been doing this for a while and you're not better, like, why don't we try something new? Like, let's call it an experiment, not a lifelong recommendation. And again, I think you can kind of get people to flex when there's some rigidity.
So what's the most common, this is probably not the easiest question to answer, but what's the most common complaint that patients are coming to you with in this
Bloating.
kind of age demo? What is it?
Bloating.
Bloating.
That's actually a very
Across the
easy question. It's always bloating.
Yeah. It's always bloating and they're always full of stool.
Okay, so give me answers.
Yeah, why am I always bloating,
Why is a
Pash?
40-year-old bloating? Yeah.
We'll talk about you offline. How about
Oh,
that?
just want this to be my own, appointment, but fine, go
Your own
ahead.
appointment, like urge to,
Yeah, I'm
yes.
multitasking. Get it all done. Go ahead.
I mean, I think Yevgenia would agree that the number 1, 2, and 3 reason that we see for people being bloated is that they're 100% full of stool.
Or you could use it.
Full of shit.
Yes.
I
Yeah.
was trying to be good.
No, you're great.
And this is not, it's like, but I go to the bathroom every day. I was like, yes, but there's about 5 pounds left in there. So, that is extremely common. But as a matter of fact, as a plug, that little book behind Tamara is all about bloating that she wrote. So we have a plethora of causes. So just because somebody's coming in with a symptom does not mean it is a unifying diagnosis. So a lot of times, oh, I'm bloated, I must have SIBO. And I'm like, actually, no. Or, I'm
What's SIBO?
bloated.
What is SIBO?
Small intestinal bacterial overgrowth or bacterial overgrowth syndrome. So
In your small colon.
in your small colon.
In your small colon. Right.
Um,
So, okay. So, but is SIBO something that people like, do they read about on the internet and they're like, I have SIBO, or is it just
oh, yes,
common?
that is the most common one. Yes.
That it's the most common reason why, or I guess the etiology that people will come in and say, this is what I have, not
Yes.
diagnosis that you give them.
Yes, it's like, I think I have this, I want to be tested for this, or,
Gotcha.
Yeah.
Gotcha. What's a regular amount of, when someone comes in and they say, I'm bloated, and you're like, but are you saying you're constipated? Or are you telling them they're still just, you're full of shit?
Well, we're asking about their bowel patterns. We're asking how often they go to the bathroom, how much stool comes out when they do go to the bathroom.
We show them
how-
poop charts to quantify this.
Yeah, what does it look like? Does it feel like it's complete or not? And then we kind of compare that to how much fiber they eat. And if they say, yeah, I go once a day and it looks normal and it's like a medium amount, and then I look at their diet and they're eating like massive kale salads with chia seeds, flax seeds, oatmeal, nuts, berries, whatever, and they're just pooping once a day and they're super bloated, then you're thinking, well, it's great that you go every day, but the amount of fiber that goes in is not even close to being commensurate with the amount of stool that you put out. There's a fair reason to believe that you're probably very, very full of stool. And so there's a lot
does
of that.
dehydration come into that? Is there a hydration part of
You
it?
think so?
Well, hydration wise, I mean, it's a matter of you need fluid and fiber in a particular balance, sort of for normal bowel function, but it's usually, I mean, I could have people who are drinking gallons,
Yeah.
feel constipated. So it's not linear necessarily, because there's a lot of different underlying reasons for constipation to begin with.
Yeah, most people can't drink their way out of constipation.
Right.
Gotcha.
Yeah,
So,
Is the
guzzling
diet?
water alone is not going to do it.
Yeah, it's
Eating
not
buckets of
gonna.
fiber is not going to do it. It all depends on the individual person.
You need
so
a
is it
plunger.
usually because of slow motility? Is that the reason why these people are usually full of poop or
So it's a
something
combination. There
else?
is slow transit constipation. There's normal transit constipation where you're just, some people it's just because they're eating so much that they just can't keep up with it, fiber wise. Some people it's just they're just prolific poop makers, even though they have a low fiber diet. That's just what their body does. Some people it's pelvic floor dysfunction. So, your colon does its nice little job with motility and then it gets down there and the door's locked, so everything still stays. Sometimes it's a combination of all of the above. So, a little bit of this and a little bit of that.
And how would we fix
Right.
this?
Someone comes in and they're eating like the kale green diet, too much fiber. What's the fix? What's the fix? I mean, unless the fix for a low fiber diet is just increase your fiber intake.
Well, if they're eating too much fiber, like if they're not keeping up with it, we like to say that they're adding more cars to a traffic jam at a certain point.
Yeah.
So I am having them really pull back, not like necessarily in an overtly low fiber diet, but I'm having them pull back on the amount of sort of what we call high residue, like roughage, intact, coarse fiber, salads, peels, skins, like the real roughage type of stuff, and try to move them into sort of what we call GI gentle fiber, which is cooked things, skinless things, mushy kinds of fiber, and not to be supplementing fiber. Like it's plenty of fiber to have like oatmeal in the morning with like a little bit of, some fruit. You don't need to also add fiber to your fiber. You don't need to put the chia and the flax and the nuts. You can just have like regular oatmeal with like a little bit of fruit. And so we're kind of like pulling back on the amount of fiber. And then in tandem with that, some sort of bowel regimen, whether it's a prescription one that Yevgenia would prescribe, whether it's over the counter, something to help them also get more stool out so that you have less going in, more coming out. And after a period of time, you start to really, balance out.
Is the I was going to ask about magnesium in this involvement in this kind of process, but in terms of fiber and fiber supplements, I want to say that a lot of people are on extra fiber supplements. So who should be taking those? And like you said, who should not be taking those?
So we use fiber supplements for all sorts of people. So sometimes I'm more inclined to use a fiber supplement, believe it or not, in someone who has chronic diarrhea than who has chronic constipation, because a lot of the supplemental fiber does a really good job, like sucking up extra moisture and bulking and really creating form out of liquidy mush. So a lot of the time we're going to use supplemental fiber for like mushy, soft, frequent, loose bowel movements. We will sometimes use it for certain types of constipation. If someone just has like a super duper low fiber diet and they are very picky eaters, they don't like fruits or vegetables, they're like college boys, and then like maybe they'll really benefit from, something like that. Most forms of pelvic floor dysfunction, we're very cautious. We typically don't love to supplement fiber, and someone whose back door might not be able to empty fiber very well because you don't want to like jam them up. There are some exceptions, like, sometimes patients who have like a very weak pelvic floor or like a rectocele that actually have an easier time passing a very bulky log-like stool, but they really have to squeeze and strain to push soft, mushy stools or hard balls. Sometimes we will use fiber just to get the texture right so that their muscles can really pass a cohesive, complete stool. But like it's very individual. Like there's no like you should have it, you shouldn't. Like you really need to like see what they're eating, see what their poops look like, see how they do best, like how they execute pooping best, and then decide if there's a role for a fiber supplement or not.
How do you know if you have a weak pelvic floor?
Multifactorial options, but this is the questions that your doctor should be asking you, and a lot of patients already know about this, but it's about your GI function. So, okay, you have to constantly struggle and strain, even if your stool is normal, you're getting into funny positions, you're trying to digitize to evacuate stool, you're getting enemas. I mean, all of these things are very much, something is not opening, or it's like, I feel like it's there and I just can't get it out. Conversely, having a hard time holding stool and having a hard time, being continent, both urinary and GI. Also, dysfunction, sexual dysfunction is another part of your pelvic floor because it involves multiple compartments. It could also be related to, low back pain, pelvic pain, hip pain, all of those muscles are part of it. So, but, the easiest, very simple test is, your doctor doing a rectal exam and kind of testing your muscle strength. And there's more formal testing, obviously, but you could easily detect weakness just on that.
And is that only treated with diet? Are there other options to kind of go along
No.
with that? What
So
else can we do?
pelvic floor is treated with physical therapy. So it's, physical therapy for your tush or urinary or vaginally, or a little combination of all of the above, which by the way is part of normal postpartum care in many parts of Europe. So after every baby, a woman will go, to pelvic rehab
Oh,
because
really?
yeah, because your pelvic floor just ran a marathon a little bit, and it's
Yep.
time to kind of patch this back together. But here it's becoming very in vogue finally, but it was very taboo and not really spoken about. And it was kind of normal to have, oh, it's totally fine to pee myself a little bit since I had a baby, and it's really not. I mean, that shouldn't be happening. We shouldn't be accepting that. So it's pelvic PT for all of those things, and all your gastro things because.
Is there a point where it's too late to kind of rehab, where you have to have surgery, or?
For some people, yes. I mean, particularly we have a lot of little old ladies, much older patients who you just don't have the muscle tone anymore. There's just not a lot of muscle left kind of pretty much anywhere. It's a lot of just generalized muscle wasting and weakness. And there's only so much better we can do with those patients. I mean, there are some limited benefits are still going to be there, but it's not going to be tip top perfect. And when it's gone for that long and there's that little reserve.
But for patients that are in that close to postpartum kind
Yeah,
of,
but anytime. I mean,
like
I have
anytime
I
you should
have,
be.
18-year-olds who need PT, and I have, 75-year-olds who go to PT. So it's any age range, and we all could probably, quite frankly, benefit from an assessment because we all misuse our pelvic floor on a daily basis. We are not meant to sit in chairs like we all are right now. We're not meant to wear shoes or walk on concrete. We are not really, we're still kind of learning the whole two-legged walk situation, evolution wise. So this whole holding up your entire body, and we're using toilets, which are about 100 years old.
Wait, you're
Also,
using a toilet? What is, I
yeah,
don't she
I don't know what those
you
are.
you gave us
Um,
like, we're using toilets? Yeah.
Yeah, yeah, that hole in the
Oh,
ground
okay,
thing is
okay.
like
Yeah.
way more in line with what
Yeah.
your body's supposed to do. So
Yeah.
everything ergonomically for that part of us is just like dead wrong. So we're constantly like maladjusting, and it leads to issues.
Is that where the squatty potty comes in?
Yes, it does. It's a
Kind of
wonderful thing.
helping the angle there
Yes, it's
of
basically
everything?
recreating the squat position without ripping out your toilet and making a hole in the ground and making it awkward when your guests come over.
Unanimously, I think every GI I've spoken to is such a huge fan of just the concept,
I mean, I just, I wish I invented it and retired.
yeah,
Clearly
yeah,
not
yeah, yeah.
very entrepreneurial.
Piece
Well,
piece of it's not all it's cracked up to be. I don't wish it for
being
anyone.
an entrepreneur or the squatty potty?
The entrepreneur piece. Let's talk about this colonoscopy because I'm 45 now, and I think this year I sent all of my friends to see Pash and get their colonoscopies, and
Yes,
Pash was like,
coerced and scared, and
She
she
did
picked
my
some of them
first.
up.
She did my first when I was 46.
yeah, she did. But I begged her to do mine, just a little shy of me turning 45. I was like, just do it. She's like,
And you
okay.
opted for the no anesthesia approach.
I talked the whole time. I don't remember this, but I woke up and Pash was like, Vanessa, you talked the entire time. I'm like, really?
Oh,
About what?
Yeah, I
yeah,
mean,
yeah.
she was chatty Cathy, but she
Yeah.
doesn't remember it. So, amnesia is still good.
It
Yeah.
worked. It
So
worked.
now all of my friends and I are of an age, and I was going to the gym with my friends. It's four of us, and we call ourselves the Golden Girls, and they're all talking about their colonoscopies. And there's one
Of an
that's
age. We're the Golden
yeah.
Girls, but we're of an age.
Well,
Yeah.
well, there's one that's
Of an
40 and
age.
the rest of us are over 45. So she's like, wait, do I have to do it? I'm like, no, 45. She's like, you'll take me when I'm going. I'm like, yes, but we're all talking about it. And these other women are like, well, I heard it was terrible and I don't know what to do. And I'm like, well, it's not that terrible. So for people who are kind of nervous about it and they're worried that it's going to ruin their lives and they're never going to recover, can you just like let them know the reason that we're doing it at this earlier age, what to expect, and why they don't actually need to be afraid?
Yeah.
So,
Yeah. An intro to the guidelines, I think, is what everybody wants to
yeah,
hear.
so I
Yeah.
mean, colon cancer is incredibly common. I think it's now like the second leading cancer, and cancer deaths. So kind of the way I put it to patients is very few preventable cancers out there. This is one of them. We really have, for women, it's just okay, breast cancer, hopefully, right? We have mammograms, we have, skin cancer because you're going for your skin checks and using your sunblock, you know, um, cervical cancer, and that's really kind of about it. Everything else is kind of luck of the draw and roll of the dice. So, and that's what's called, why don't you do colonoscopy? I was like, well, you're getting your mammograms? And they're like, oh, of course. And I was like, well, why are we ignoring one cancer and focusing on the other? Because, so it's not so scary at all. It takes, it's a night with your toilet and lots of baby wipes and, catching up on some terrible movies or, paperwork or whatever it is that you want to do. And then you get sort of, so it's a cleanse, people do cleanses all the time, right?
Ah,
Yeah, for fun,
So
Um,
interested in talking about that. That's like a different episode. Some of these videos, you just
Yeah, I mean,
what
people
is
are constantly
happening?
taking, I need a
Yeah,
cleanse, I need to, I
yeah.
was like, no, you don't.
No,
Your body
yeah,
kind of does this at its own pace. If you're really full of it, we do them, just to like make you feel better, but it's not something that you do when you're just feeling fine and
yeah.
living life. So it's, it's a cleanse. You do get a nice nap. You don't actually feel any of the colonoscopy. And you get a peace of mind for, hopefully a 10-year period, provided that, you did your good job cleaning and I find nothing. And there's very few assurances like that out there in the world for your health and safety, quite frankly. Um, the guidelines have changed to a younger age because we are seeing so much more cancer in younger patients. I mean, younger and younger, scary younger. I mean, we are, we've all had 20-somethings-year-olds with colon cancer, which is terrifying. The guidelines used to be 50 and 45 for some of the higher risk groups. It's now 45 for everyone. And the higher risk groups are actually usually kind of in 40 years old and such. And I mean, you're more likely to get colon cancer if you're born in the 1990s and if you're born in the 1960s right now, which is pretty awful.
Wait, why is that?
Is it the
Because
food?
there's plastic in all our food,
Ah,
really.
yeah.
I mean, I think if it goes down to it's the ultra processed food, and it's all of the food additives, the microplastics. I mean, that's kind of what things are boiling down to more than anything. And at this point, you can't turn back the clock. Like we've all had this exposure to all of this stuff, and they're like, "But I'm vegan," and I was like, "Well, you can be vegan, gluten free, and and doing Pilates, 3 times a day, and you could still get colon cancer, and you could also eat McDonald's every day and not get colon cancer. It's so you're not excluded. And I'm just like, oh, well, I feel fine. I don't need it. And like, well, by the time you have symptoms from colon cancer, you have really missed a boat because that's usually a metastatic cancer. It's very rare that you have any symptoms because something that's as small as, 2 centimeters in size or even less often can already be cancer. And your colon is quite large and can house something way bigger than that, before you know anything about it. So by the time there's symptoms, you're in trouble. This is the stuff, I tell parallel is, you don't wait till you have a lump in your breast to go get a mammogram. You're going proactively. It's the same concept.
You mentioned for those that are high risk. What puts me at high risk?
So risk factors are determined by, particularly now, family history. It used to be that we used to screen anybody with African American background at 45, even when everybody else had 50. Everybody's been moved down to 45. But family history is really what dictates your risk, as well as a history of inflammatory bowel disease. So people with ulcerative colitis and Crohn's colitis are at higher risk for colon cancer after a certain amount of time with the disease. And anybody with a family history of, I mean, there's tons of genetic syndromes that go along with colon cancer, but particularly colon cancer in a first degree relative at a young age, or any age if it's two second degree relatives or two relatives, that are close that have had cancer in their lifetime, makes you a higher risk individual for it. Same thing also with advanced polyps, kind of very large polyps, even if they were not cancer.
Something that I think has gotten itself into the news, and also I know my friends talk about it a little bit. I think, a patient, they're a little bit nervous. It's a colonoscopy. There's invasiveness to it. It's anesthesia. It's a procedure. What do you guys think about kind of these companies like Cologuard, these pre-screening tests? I think that's
So it's
becoming
not it's
more,
not a pre-screening test,
or a
it's
test
an
screening. Yeah,
alternative.
yeah,
It's
yeah,
an
yeah, yeah,
alternative
yeah,
test. So
yeah.
medically speaking, so colonoscopy is currently considered the gold standard test. So,
Yep.
it's kind of in medical terms, for the lay, it's the best test we currently have available because it is most accurate. It is also diagnostic and therapeutic at the same time. So not only can I see everything, but I can also remove whatever is there and you're kind of one and done, and it gives you the greatest longer term confidence interval to not have to think about this. Tests like the Cologuard, and also sometimes, there's incidental stuff that's found. I've diagnosed many people with asymptomatic Crohn's disease and, colitis, and, told them that they have diverticular disease and all of these things that they did not know about before their procedure. Um, the Cologuard is basically a fecal DNA test. It's based abnormal DNA that's being shed by kind of dysplastic lesions, so cancer or a large polyp. So this is not a test that will look for small polyps. This is not a test that can remove anything, and this is not a test that will tell me about any other parts of your colon health outside of, do you have cancer? Do you have a big polyp? That's it. And so a small polyp is not meant to be picked up by this test. So this is a test that needs to be done every 3 years, at least, because, a polyp that's small today is not going to get picked up by this test. But you know what? 3 years from now, it might grow big enough that it will turn positive. So actually, I had that happen. This week I had a patient who she opted for the Cologuard in 2021. It was still like she was nervous around the pandemic, and she was fine. And she's like, "Oh, that was easy. I'm going to do it again this year," and this year is positive. So now it's colonoscopy time.
But it's not too late. It just means that perhaps the polyp has grown large enough to kind of trigger the test.
Well, so yes
it.
and no. So the test has both false positives and false negatives. So if the test comes back negative, right? So first of all, it also, by the way, involves you playing and experimenting with poop in your house, and that appeals to some and not others. I think those with dogs,
Children.
with children and pets are pretty cool with it, but people not so much. So if it comes back negative, we say, okay, see you in 3 years, have a good life. But with the older versions, there was about an 8% risk of there being something there, including a cancer. Now I think the newer ones are about 5% risk that there's a cancer there or there's a polyp there, and we just say bye, see you in 3. The converse is you get a positive test. If you get a positive test, well, now we have to do a colonoscopy right away because now we're looking for something.
Right.
And that something could be a cancer, absolutely. Not always the first thing we think of. It could be a polyp of any variety, or there could be absolutely nothing there, and that's the false positive, which, I always go over all of these statistics with patients because what we get is, panicked, crying people on the phone. It's like, oh my God, I have cancer. And I'm like, we talked about this. I did not say this is going to be a positive test for cancer. It's like, we have to look further now. So it does lead to a lot of anxiety in that in-between range for a lot of patients who.
Is there an algorithm kind of in your practice where you're like, okay, 100% you have a first-degree relative with a history of colon cancer at 45 or earlier, you're getting a colonoscopy. Done.
Oh, yes.
You don't have that. You're 40. Are we having them get a Cologuard, or are we waiting till
Cologuard is
45?
only approved as a screening test for
That
the
was my
age
question.
population. So it is for age 45 till 85, I believe, is their current approval. When they first started, they came out, the guidelines were still 50. So, they had to do some additional data to make sure they validated for the 45 to 50. But it's an instead of, and it's only for the average risk asymptomatic. So if you have a family
Right.
history of colon cancer, this is not for you. If you're coming to me, you're like, oh, I'm having like blood in the stool, I'm having altered bowel habits, I'm having abdominal pain, this is not for you. This is for, I feel great, all's well in the world, I'm 45, I don't want to do a colonoscopy.
Are
Go.
you telling are you telling a family member to get Cologuard, or are you telling them to get a colonoscopy at 45?
All my family gets colonoscopies, but yeah, I mean, it's I tell people that my goal is that you get screened with whatever is the method that is comfortable and acceptable to you, as opposed to me pushing anything on you and you putting it off, right? Because they said, oh, well, what would you do? And I'm like, that's not a fair question because I've probably done a lot of things that you would not do and vice versa. So, like I used that line on a patient once. I was like, well, I've jumped out of an airplane before. And she's like, well, so have I. And I'm like, okay, that has always worked, but it did not work today.
But also, if you can jump out of an airplane, you could totally get a colonoscopy.
Right. I mean, quite frankly, like you've delivered a baby, you get a
Yeah.
colonoscopy. Like I've, had multiple surgeries, not once had any qualms about walking into those. Both times I went to deliver, I nearly crapped myself, just because of how badly that could go wrong in like seconds with no control, right? Like it's a completely uncontrolled situation, really, as opposed to all of these procedures, which have, controls and
Right.
guidelines and, and tools. So,
And it's okay that you crap yourself during them.
yeah, it's totally fine because you won't
Probably
know.
preferred.
We're wearing,
probably.
I'm wearing like a rubber, like a sexy little rubber outfit, and we don't really care if poop gets on us. It's really not a big deal.
Do
Yeah,
you?
they like it when the poop gets on them. Like
Yeah,
that's
exactly.
I wouldn't push it, but
You're like, it really is interesting to watch a colonoscopy from a healthcare perspective because, you guys, you're like, wow, the prep really worked. It's clean. We got a great, pictures. We got great views. it's really an interesting kind of cool procedure to be a part of.
Yeah, and he's like standing at the sun going like,
Yeah, but also
whatever.
disgusting. Yeah, yeah. Well, my perspective is very different. My perspective is very different. So yeah.
I have a question. I'm going to shift gears now. My next question is, because people ask us this all the time, so I guess probably mostly for Tamara, which is people come to us and they're like, I have this really bad gut health and this is why I'm overweight. So can you please debunk
Wait, what do you
these
mean they have
myths?
really bad gut health? Like I'm
Like
overweight
I'm
and
overweight
Yeah.
because my gut is unhealthy.
Yes, there's and most of the time it's because they took some test that's not worth the paper they're printed. It's
The
printed
GI
on.
probably.
Yeah, that's telling them that they don't have enough of this bacteria or this bacteria, so they have bad gut health, and this is why they are unable to lose weight or the reason why they have gained weight.
So, I mean, similar approach to what I outlined before, which is, okay, let's see if I agree with that assessment. Let's look at what you eat and, take a detailed diet history and what their eating habits are and their exercise habits are. And I'll let you know if I agree. Like, if your diet is like this, this, I don't even want to say perfect. I don't even know what a perfect diet is, but like if your diet is very nutrient dense, it's really, high fiber fruits, vegetables, moderate in, calories, like, minimal snacking and like lots of real whole foods, and you're exercising a ton and you're putting on like, 10 pounds a year. Yeah, I'm probably looking for something other than you're overeating. And whether that's in your gut or whether it's in your thyroid or whether it's, sex hormones, like that's, potentially, getting doctors involved, endocrinologists involved, etc. Um, I'm more inclined to believe that like a weight gain is at the cause of something sort of dysbiotic if it starts happening rapidly after like a major GI disturbance, such as a course of like a blitz with antibiotics, and all of a sudden within the next year, you've gained 15 pounds. I mean, if there's been sort of like a very clear and obvious disturbance in the gut microbiome, or like I had um like a perforation or something and a major GI insult, and then I had this like surgery to correct it, and all of a sudden like I'm putting on tons of weight, or I had C. diff and I got treated with like crazy vancomycin, and now I'm like my weight's out of control. Like I'm much more open to that possibility than like, hey, it's menopause and I'm slowly but surely trending up every year and it's because my gut. Like that's not your gut.
Yeah, I mean,
What
we
is
know
it?
that the what is it? We know that the bacteria are basically, the few trillion, fun little pets that we have, um, that live in and on us at all times. They control everything. They control it, including obesity, mental health, inflammatory conditions, cancer. I mean, they're implicated in everything now, but we don't know how to manipulate them yet. We don't know how to select for, okay, I'm going to pick out this little batch. And also your microbiome is, it's like your fingerprint, yours is going to look different than mine, than his. It's completely different and it's related to so many factors and life exposures. But we have seen this happen, we have seen, fecal transplants where, somebody gets a fecal transplant for, refractory C. diff, which is which is the only FDA approved indication before anybody else asks for one, because, that happens a lot. And, it's people who were like super skinny that became obese because they got repopulated with completely different bacteria from a person who has a very healthy gut. So that's the other important bit, is just, gaining weight or being overweight does not mean that you have an unhealthy gut. That is just the microbiome that is more hospitable to that, but it doesn't mean it's unhealthy.
I think that I like the microbiome kind of angle that we're talking about. So I want to bring up the probiotic, the prebiotic, and then also antibiotics. I think that people kind of not have misconceptions about antibiotics, but like we kind of talked about it earlier. Can you guys just discuss your thoughts on starting someone on these prebiotics, probiotics after assessing their diet? And then we can kind of touch on obviously the negative side effects of antibiotics, I think, in your gut biome.
It's actually a pretty straightforward conversation, which is
Yeah.
I almost never recommend probiotics for anybody. Like there are very, very, very few indications where I'm recommending a probiotic for someone.
3 to be exact. One of them is in neonates, so it doesn't apply to our patient population.
Okay. And so who else?
pouch patients, so people who don't have a colon, which also does not apply to the majority of the population. So particularly
Okay.
it is known to decrease inflammation in a pouch in somebody who's had their colon removed and has a J pouch. And, C. diff related, kind of antibiotic exposure, which is
Yeah.
Florastor, which is the only one that we sort of recommend because it's, less harm than some of the other ones are.
Just because their flora has been kind of decimated by the antibiotics, so the probiotic is just kind of to rebuild.
Not necessarily. I mean, I believe that Florastor specifically has been shown to be protective against C. diff because I think it's probably competitive inhibition of that particular probiotic yeast strain. I mean, I think it's something very specific to Florastor. When you take a probiotic, you are not like completely like profoundly changing the microbiome, right? I mean, you've got like 1,000 or something species in there. I mean, I always tell my patients, think of your microbiome as a rainforest, right? It's a very complex symbiotic ecosystem with so many interdependent species doing things together. What do you think would happen if you walked in there with like, to the Amazon rainforest with a single eastern tree squirrel and just plopped it into the Amazon rainforest? What do you think that single tree squirrel is going to do in this ecosystem? Probably very little.
Mhm.
Maybe like one out of every, 1,000 tree squirrels that you happen to drop into some random ecosystem is going to find an ecological niche and just happenstance do something incredible.
Yeah.
More likely, it's going to do nothing and it's going to die and do nothing profound in that
And
ecosystem.
cost you a lot of money.
So like it's just there's really such minimal evidence to support benefits for probiotics for most people, and like actually some indication that taking probiotics after an antibiotic could actually be harmful, contrary to all of the sort of like, common sense wisdom out there. So like we are really like more and more shying away from them.
So
All the
this is
GI
like
guidelines are against recommending them.
right.
Whoa, you're just like taking down every influencer on the gram, and
Yeah, I was
it's
gonna say, I mean, so
amazing.
this is all just capitalism. I mean, this is just all business
Yes.
I explained,
driving
I was like,
this.
probiotics did not exist about 10 years ago at all. They were not on the shelves, period. And
I
somehow
mean, they are
survived.
everywhere in
Guys,
stores.
I say to everyone when they're like, I take probiotic, I'm taking this probiotic. What do you think? And I'm like, I don't know. Tamara and Pash, they don't recommend them. So if they don't, then I think it's probably
The
not
Yeah, I
last
mean, you
right.
know what? I have people that come to me and I was like, why are you taking this? And they're coming in for something like routine. They're coming in for screening colonoscopy. I was like, why are you taking this stuff? And it's like, oh my God, I had all this IBS, 10 years ago, and since I've been taking this, I've been perfect. I'm like, fantastic. You have no contraindications. This works for you. You want to spend the money? By all means, data or
Yeah.
no data, I don't argue with what works. But generally speaking, when people are coming to us with symptoms, clearly, like Tamara was saying, that's not working.
Yeah.
And there is plenty of data to support why it's not working and what kind of issues it can. I mean, what Tamara was saying, they actually inhibit your normal's body repopulation and recolonization of your normal flora when you're throwing them in, when your flora has been a little bit decimated, because those bacteria in that bottle may have nothing to do with what lives in your gut and likes to live in your gut. And now they have much more room to set up shop because your guys are a little beat up. So you have to let your own body recover. And the whole, I'll let Tamara speak on prebiotics, which is a whole different thing. That's more like food for your bugs as opposed to introducing new bugs into the
Yeah.
system.
I mean, just like one last point on the probiotics. I mean, one thing that actually worries me more than just like, what does it mean when you delay the restoration of your own native microbiome? Like, okay, that sounds like that's annoying, but fine, it'll eventually come back. The problem is there's some indication that the longer you inhibit your own baseline microbiome from kind of rebounding, the greater increase in antibiotic resistant genes can flourish within your microbiome. In other words, there's some indication now that taking probiotics after antibiotics actually increases the resistome or the reservoir of antibiotic resistant genes in your microbiome. And that's really freaking bad. And so this idea that like, oh, well, I never use a probiotic except after I take an antibiotic, like that might actually be potentially the worst time to take a probiotic.
Are you rebuilding your gut biome differently now that you're kind of populating it with this probiotic? Is that kind of what's happening?
You're
Yeah.
delaying your normal microbiome from rebounding back to its own baseline by introducing interloper species that are now occupying an ecological niche that is supposed to belong to one of the native flora. And that's not great, potentially, especially with regard to antibiotic resistant genes, it appears. So, it's not just like, well, maybe it doesn't help, but it's not hurting. Well, actually, like maybe it is hurting. Like we don't actually know that it's
Right,
not
right, right.
hurting. And there's more and more, indications from microbiome researchers that maybe it's actually hurting. So we're not fans.
Is there like a time frame? I took antibiotics for something for, 2 weeks and now I have some GI symptoms. Is there a time frame as to how long it potentially takes to kind of regrow my gut?
So I think that for most antibiotics, except for like Cipro, it's usually within about a month your microbiome is back to normal and sometimes even faster. And a lot of it depends how quickly you resume your usual diet. Like a lot of people coming out of like some sort of illness is eating really bland, the tea and toast, like, chicken and rice. The
Right.
best way to rebuild a microbiome is with your normal diet, especially if it has diverse sources of fiber. So if you want to restore your microbiome, what I tell my patients, forget probiotics, like eat diverse fibers, make yourself a smoothie with 7 different fruits and vegetables, like make a soup with some lentils and 5 different vegetables in it. Like get that diverse fiber back in your diet quickly and your microbiome will bounce back because you're feeding it. And that really tees into the conversation around prebiotics, which are basically, it's just fiber. Prebiotics are very fermentable forms of fiber that are preferentially fermented by some of the more favorable species of bacteria, namely bifidobacteria and lactobacilli. And so these are fibers that these guys preferentially eat and love, and they seem to increase the abundance of these beneficial anti-inflammatory short-chain fatty acid making species. So if you want to support your microbiome health with a supplement, you will probably do a much better job promoting favorable composition of your microbiome by eating prebiotic rich foods or even taking prebiotic supplements if you tolerate them, because they can be very gassy, more so than by actually taking a probiotic bacteria strain itself.
So we're not repopulating the gut with this novel, I don't remember the example of the howler
Tree
monkey,
squirrel.
the tree squirrel that you
Yeah, if you dropped a rat in there, though,
yeah.
I don't know. I feel like
Yeah. So we're not repopulating with the tree squirrel. What we're doing is we're kind of trying to feed and grow our existing.
yeah, you're
Exactly.
basically
That sounds
throwing in
wonderful.
lots of fertilizer,
Fertilizer.
and
It's
rainwater.
fertilizer.
Yeah.
Fertilizer. So why aren't we all on prebiotics are not a supplement. Prebiotics are foods.
They
Or
can
both.
be. So look, historically prebiotics were foods, right? Like people got prebiotics by eating beans and, onions and garlic and artichokes and, asparagus and, barley and whole grains. Like people used to get their prebiotics just from eating diverse plant-rich foods. Nowadays, everyone wants to supplement. People want to market supplements. And so now people are now marketing prebiotic supplements that are either isolated from food or manufactured sort of in a lab to sort of have a prebiotic effect. And people are supplementing it, which, look, prebiotic supplements should work in terms of feeding bacteria. It's not like it's a bad thing, but there are certainly many, many more benefits to eating whole plant-based foods that have prebiotics in them, as well as antioxidants and vitamins and minerals and things like that. And so, I'm not like as opposed to prebiotic supplements as long as somebody, can tolerate them, but I don't think that they are a substitute for a crappy diet.
Yes, the crappy
Yeah.
diet is
Yeah, the crappy diet with the little
This
fruit
is-
veggie supplement gummy drops.
Yeah, this is
I'm
the
doing it.
conversation.
I'm balanced now.
I'm always like, Cash, I'm sending you this patient. I'm not quite sure. Is it because their diet is trash or do they actually have a problem? So
Yeah.
we're gonna tag team.
Yeah,
this.
we've had this conversation before, Vanessa, and we
Yeah.
always it always I think I was tested for SIBO. I've done the whole thing.
Yeah.
Would there be 3, however many you want, superfoods that you guys are eating that you recommend? Let's say normal diet, no IBS, no IBD, whatever it is, no contraindication to eating those foods that you guys would recommend to patients overall.
Beans.
What?
Beans.
Beans.
Yeah, the superfood has always been beans and will always
Always.
be beans. I don't
Beans.
care if today somebody says it's kale, asparagus. No, it's always
Always
beans.
beans. It's
Any
always
type.
beans.
Black bean, lima bean.
All
anything.
beans.
All
Beans,
beans.
depending on where in the world you live. So if you look at the world's longest living, healthiest populations, the only thing dietarily they have in common is that they all have beans part of their daily diet. Beans are the only food that have been independently linked to longevity in a dose-dependent manner. Beans are absolute freaking superfood, and if you can tolerate them, you should eat them pretty much every single day. It's one of the best foods a human being could eat.
That's why they say the more you eat,
The more you,
the more you toot.
I
So
feel like
let's eat
that's
beans at every
not why
meal.
they say it.
Yeah.
What beans do you
the
eat every
magical
day?
fruit.
Fruit. The
The
more
more
you
you
eat,
eat, the
the
more you
more you
toot.
toot. Yeah,
Oh,
come
I see.
on.
The more you toot, the better you feel. So let's eat beans at every meal.
Yeah, that's
Yeah,
true. Yeah,
I'm
yeah.
not the only one who knew that,
I've
right?
heard this before.
I
Yes.
knew it. I knew it. Wait, we don't have that much time left. But wait, Tamara, do you eat beans every day?
Yeah.
Every day, but probably 4 or 5 times a week.
What's your favorite
Why,
bean?
she's gonna live forever.
I am. I mean, like, they're probably the three that I rotate the most are black beans, like in a Mexican-ish situation. This time of year, I do a lot of white bean soups, like a white bean, like rosemary soup situation.
Mhm.
And then like chickpeas and lentils, like to varying degrees. We do lentil soups. I throw chickpeas in salads, but
She
beans are.
really loves the gigantes.
I
Oh,
love
Delicious. A
gigante
Greek
beans.
gigantes,
My
delicious.
favorite, but like I don't make them. Like I've made them like 4 times in my life, and they're hard to find at a restaurant, but they're like my favorite.
do
Oh,
you
there's some.
think because I ate rice and beans every day of my life for literally 18 years
That's why you're
that
crazy.
no, but
Oh,
like that's like gives me like some like
It gives you an
superpower.
edge.
some
Gives an
juice
edge.
like because now I'm kind of fallen by the wayside, but I'm back on the beans.
What makes you? Are you talking when you say not tolerating it? We're talking about bloating. We're talking
Gas
about
Bloating.
bloating,
gas.
yeah. Some
Gas
But
people
bloating.
what's an alternative? Because like maybe someone gets bloating after they eat meals like that.
So there's ends like you can. Well, first of all, not all beans are as gassy as others. So like something like edamame is actually a lot less gassy than other forms of beans.
Delicious.
But there's beanzyme, like it's just like an enzyme supplement that humans don't have the enzyme to break down a certain type of gassy fiber in beans called galacto-oligosaccharides. So you can just take that when you eat beans, similar to how a lactose intolerant person might take lactase with their ice cream. So you can always just try taking an enzyme with them if they're too gassy for you.
I told you she had all the answers.
Yeah.
I
So
told
you
you.
just take the supplement and everybody around you reaps the
Appreciate
benefit,
that.
appreciates it.
Yeah. My
Oh,
favorite bean is fava.
Ooh,
Ooh, that's so Mediterranean.
that is.
yeah.
Although gigantes is Mediterranean. No, I mean,
I
I feel
like
like
I like an
every Greek
habichuelas.
restaurant out there.
I like habichuelas.
Yeah,
Like
I
What
mean,
is that? You're
I
gonna
will
throw
say,
around
I won't say no to any
habichuelas?
bean, right? But
Yeah.
like, I've never made fava. Like I'll make black beans, I'll make garbanzo. I mean, but
A bean
fava
puree.
seems very, yeah. I mean, like if you're puree sauteed, I mean, you don't,
I
you
mean,
could soften it up and make it easier. And it's also, you don't have to eat like a bucket of them
right,
necessarily.
like a half cup B,
Half
yeah,
half
cup,
cup,
half
half
cup.
cup.
half
Wait,
cup,
why aren't we
baby.
doing, what about sexy rice and beans, Vanessa?
Yo, let me tell you. You want to go to Nyack, New York right now? Yaya's got rice and beans on the stove, and I
But not
wish
sexy
I
rice
was.
and beans. Yeah,
We can call it sexy rice. Actually,
right.
my mother uses jasmine rice, and she takes the small red kidney beans and she boils them, and then she stains the white rice with the water
Oh,
from the bean.
Pretty.
Yeah, you've eaten that rice. My mother, Benji is the son she never had, and he's a doctor. So she's like, every time I
can
talk
I
to
get,
her,
Wait, what am I
you're
chocolate?
gonna, no, you gotta come. When you come to Nyack, you're gonna come. And
Excuse
then
me, I live in Nyack. Where's your grandma's house? I'm going there for dinner.
if I text my mother right now and I'm like, my friend Tamara's coming for rice and beans for her and her children, she'll be like, yes, come,
why
come
don't we
My
now.
do an
children,
episode
they don't
from
deserve
there?
they don't deserve your beans. I'll
We
go
should
eat the beans.
we should go to Yaya's house, all
Yeah.
of us. All my
Yeah.
mother wants are for doctors and very smart people to be in her ecosystem. So yes, we can go to Yaya's.
I love it.
We can get this food. My mother, guys, I have had cancer and I will call my mom today and the first words, she'll be like, how are Catherine and Rocco? Good. How's Benji? Benji is also fine, mom.
Benji is craving your rice and beans right now.
I'm gonna do that. That's why I'm
With
gonna do
Beano,
it.
with a side
Of
of
With the
course,
side of
with a
Beano,
side of
yes, of
Beano.
course. Now that will be served at your
Yeah.
table.
Yeah,
Guys, this was a
I gotta do
very
this. This is
this was
great.
a good episode. First of all, I want to say something. Tamara is a author. She has written The Bloated Belly Whisperer
Whisperer, yeah.
and regular. And I just want to say that one time my brother-in-law has diverticulitis and he was having all these GI issues. And then one day he sends me a picture of the book and he's like, I just devoured this book and this person is so amazing. Do you know of her? I just wrote back, LOL. Yes. Yes, I do know of her. I'm so glad you
I gotta get a copy.
I'm so glad you bought this book.
It's
Thank
also it's been
God.
translated into multiple languages now, so you
Wow.
could also buy it in a,
It's in Russian.
yes.
Do you have a third book coming out?
No, not right now. But
Yeah.
but my
See?
bloated belly is coming out in Chinese, and that's regular in Russian.
I
And
love
bloated
this.
belly is coming out in Hungarian soon, and it's in German.
And
So,
do you know how to say bloated in German?
Ooh.
How?
well, bloated belly is Blähbauch.
Blähbauch.
Oh,
It sounds exactly like it feels.
wow.
I like
Okay.
that.
I like it.
Yeah.
I think we should revisit this podcast in the next
Only if
few
we're being
months.
fed some of your mom's food, I
Yeah.
think.
Yeah.
No.
I know. I thought
Yeah.
you were gonna feed us, and now I'm still in the office, and it's like 6:30 at night, and
Yeah.
you haven't even fed me. So,
Tamara,
Sponsored
next
by
time I
Beano.
go to Rockland, I'm gonna text you like the day before, and then you just like meet me at my mom's house, or just give me your address and I'll drop it off.
sounds great.
Wait, I mean, you can bring it back.
My mother has gone to Mount Sinai Hospital with food for Benji.
Yeah, these beans travel. That's a great name
Yes.
for I don't know if
These
that's a
are-
rock band, but maybe that should be her
Yes.
company.
The
Yeah.
That should
sisterhood
be
of the
her
traveling
company.
beans.
These
She
beans
also
travel.
makes really good hot sauce. Haitian people make a hot sauce. It's called pickles, and it's like cabbage and cloves and garlic and vinegar, and it's just like very aromatic. And there's heat, but then there's this like floral aftertaste undertone. And I'm like, Mom, we could really crack into this hot sauce industry. And she's like, I'm not doing it, but it's very good.
I
I
watch
think-
Top Chef. I know all about pickles. Okay,
Yep, it's
Wow.
good
like
stuff,
it
guys.
gets a lot of airtime on Top Chef.
It's legit. It's very
I
legit.
believe it.
Get a
Bring
lot
it.
of hot sauce.
Thank you guys
Thank you,
for
guys.
taking the time. It's time for dinner now.
It's good to see you
Vanessa,
both.
we got a lot of new great episodes coming up. I'm excited
Yeah.
to see your face more and to
Me too.
have guests, although these guys have set the bar.
They're up
very,
here.
very-
Okay, cool.
Well, you guys can
Good to see you
find
guys.
Kalina Health on the website, kalinahealth.com, or you can go to Instagram at Kalina Health. And if you haven't already, please, please, please be sure to subscribe to our podcast, Easy to Digest, for more interviews, insights, some awesome, awesome episodes just like this one. Thank you, everybody, for listening.
Thank you guys.
Thanks, everyone.
Bye.
Thank you for tuning in to another episode of Easy to Digest. If you have questions or topics you want to discuss, send us an email at podcast@kalinahealth.com. We love hearing from our listeners. And remember, that's podcast@kalinahealth.com.
Yes, absolutely. We may be medical professionals, but we've also been through some real stuff ourselves. We want this show to feel like you're hanging out with your healthcare providers who can give you the inside scoop.
But hey, a quick disclaimer. As good as this podcast is, and as smart as our guests are, we are not here to replace your own medical providers.
That's right. So stay tuned for our next episode. And until then, take care and be well.